afternoon, everybody. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to our afternoon session. It will be on andrology and sexual dysfunction. Our speaker for today is a pioneer in the subspecialty, Dr. Ajay Nehra, and he's the president-elect of the International Society of Men's Health, urologist and professor at the Massachusetts General Hospital, Harvard University, Boston. Dr. Nehra is well known, actually. He's a figure. We read his publication. We have the honor to see him today. And we'll start the afternoon session with the AUA lecture. So, Dr. Nehra, welcome to Riyadh, and you can start your talk.
Thank you very much. Assalamu alaikum. Good afternoon, fellow panelists, executive members of the Saudi Urologic Association. On behalf of the AUA, it's a pleasure to come back to the kingdom. I've been here a few times in the past, and it's always a privilege and a pleasure, and seeing the dynamic changes that are going on within the kingdom itself. It's my pleasure. I'm going to go through a series of, we have 5 lectures. We will pace ourselves, but I want to keep it in the time context, so I've asked our moderators to keep me in check. And let's just go on to the next first one. Our take-home messages were basically, we had 140 posters in this specialty, 84 podiums, 5 plenaries, 6 courses, and 12 videos. And I'll start right off. One of the keys is long-acting, perioperative, local anesthetic blocks. Because you have seen in the United States, we are currently in an opioid epidemic. And as you saw, President Trump 2 days ago labeled this a major epidemic, and the state of Massachusetts, where I currently am, Boston, actually is the core epicenter of looking at this pathway. And here the authors were trying to see, in order to limit opioid administration after placement of an inflatable penile prosthesis. So they used ropivacaine, lidocaine, sodium bicarb, and dexamethasone combination to infiltrate the crural spaces, the ring block, to get a ring block, and the external inguinal ring as well. Interestingly, 83 of 85 patients required no opioid prescriptions. However, 12%, 11.7, did require a subsequent opioid prescription within the first 30 days itself. And that's what their goal is. So a lot of these are being done outpatient, some 23 hours. Rarely do you keep a patient in the hospital itself. In the field of hypogonadism, this was a moderated poster, and there's with shift changes, shift in terms of work hours. You have daytime, evening, or nighttime shifts. The authors here looked at a risk of hypogonadal symptoms of shift workers with sleep disorders. And as you all know, sleep disorders, whether it's restless leg syndrome, obstructive sleep apnea, are 2 major risk factors for ED itself. Absolutely. In the shift workers here, you're able to see low risk versus high risk, and looking at the ANOVA comparison with a p-value of less than 0.01. You saw worse hypogonadal symptoms, lower T levels as well. And the authors subsequently, the next manuscript looked at obstructive sleep patterns, and we've published on this as well, where we looked at obstructive sleep apnea. Typically, what we see is young males who are truck drivers, who are obese, have a collar size greater than 18. They are predominantly have obstructive sleep apnea symptoms, and the pathophysiologic, and this may be a board question, pathophysiologic sequelae in these young men is not arterial insufficiency, it is corporal veno-occlusive dysfunction, or CVOD itself. The final moderated poster on testosterone hypogonadal looked at TRT replacement for age men cohort, and we're going to talk about cardiovascular event-free survival for TRT users. And I think with sleep apnea, this was very important, but event-free survival in sleep apnea patients were worse in TRT users, as one would expect itself. All right, a reproductive slash andrological moderated poster. Novel, very novel. Leydig stem cell isolation and differentiation from human testes biopsies. Potential modality to increase serum testosterone. So what they did is they extracted, they used a mouse model, but then they went on to do testicular biopsies from humans. They were able to differentiate Leydig cells in an in vitro condition, and they were then xenografted under the skin in mice to increase serum testosterone and preserve the HPG axis itself. And you're able to see that, how the serum was harvested and the skin grafts performed itself. So it's a novel process, and I think you're going to see this manuscript come in. It's going to be reviewed intensively, critiqued intensively, but this is now a pathway where we may be looking at future modalities of testosterone function itself. In the field of erectile dysfunction, bicycling is a major exercise inducement for men and women in North America, certainly in Europe as well. And the impact of cycling on men's sexual and urinary functions was evaluated. As you will recollect, one of my mentors, Urban Goldstein, published the first manuscript on bicycling in men predominantly. And this particular poster presentation looked at 3,900 men who were non-cycling athletes, and they had, cyclists have no worse erectile function than non-cyclists. They were not associated with LUTs or UTIs, may be associated with development of urethral stricture disease, which I think is a common prevalence here, and we're seeing a much higher prevalence of urethral stricture disease, both from sexually transmitted diseases and for traumatic injuries such as this over time. Because what happens is your crura are protected, you start developing a venous leak, but more importantly, the urethra is unprotected, so you start getting at the bulbomembranous area changes in urinary stream pattern over time itself. Another poster looked at the impact of cycling on women's sexual and urinary functions, and this was greater than 3,100 female athletes looking at cyclists versus runners and swimmers. No significant differences between cyclists and non-cyclists in the mean storage and voiding subscores of IPSS, nor the total IPSS score itself. After adjusting for age, cyclists had a higher odds ratio of self-reported UTIs and perineal numbness compared to these runners and the swimmers itself. Looking at anatomic mechanisms for change in penile length after radical prostatectomy, when I was at Mayo Rochester, we always recommended for all the oncologic surgeons for men to have a preoperative in the OR flaccid and penile strength length measurement documented in your operative note. And that's why you could follow along over a period of time. Here they did stretch penile length measurements preoperatively and at 10 days, 1, 3, 6, 8, 12, 18, and 24 months following a radical prostatectomy. Overall, 102 patients with a multivariate analysis predicted a penile loss length at day 10 itself. More importantly, pelvic MRs pre and post operatively showed that the vertical repositioning of the membranous urethra occurred at day 10, and the mean change that occurred at 10 days of 4 millimeters, but it recovered length at 12 months. And I think most of you who are practicing andrology, there's a certain predisposition to recommend the use of vacuum erection devices, not for ED management, but for length preservation, because what happens is this data shown that the tunica albuginea starts to contract, and really it's the tunica that you want stretched out as you initiate rehabilitation protocols at the cavernosus smooth muscle level itself. So I think that's where you want to be able to preserve length as well. Kevin McVeary, looking at new technology in implants, and I think you're going to see over the next 5 to 7 years a number of authors coming up with new technologies on it. This was a nitinol prosthesis itself, custom fit to the patient by using a 3D printing and activated to the erect state by change in temperature. So, you know, these are some of the things. Now, is the change in temperature, if we step out in the sun, is that going to be a major issue here? Those are things that will need to be evaluated, but I have a feeling they will need to refine it to the basal body temperature itself over a period of time, and we're going to hear from these authors as well in the future. Role of prosthetic infections, and this was the risk of subsequent device infection at revision surgery, strongly correlated. This is very well known, but again, a good manuscript, and increased linearly based on the number of prior implants. So if you do 2 prior implants, the risk goes from 6 to 18%, 3, 33%, 4 prior, 50%, 5 prior, 100%, all the numbers are very slow. I can tell you there's ways to mitigate that, and there's ways to evaluate that intraoperatively and preoperatively, so we'll discuss that in some of the case presentations as well. Again, prosthetic infections, you're seeing that the organisms that are changing because of the use of bacteria that cause infection are indeed changing. And here, what you're able to see is for the first time, folks, you have MRSAs, Staph aureus, Staph epis, very well known, but in the revision, you start seeing strep pneumonia, you start seeing E. coli, you start seeing Morganellas, and Morganella is a very slow, indolent process. Even so, for all the residents in training, it's very important if a patient postoperatively compares of pain that's worsening. There's tethering of the skin. The scrotal pump in an inflatable penile prosthesis is now anchored. It's a subtle sign, absolutely, that there's the prosthetic infection itself. And one needs to look at, I've used MRIs very well to predict who may be at risk for infection just based on what the MR shows, and that's a diagnostic method of modality that one can use as well. There were two posters that looked at the idea of high infection rates in immunocompromised patients, specifically the transplant and the HIV population. And I can tell you, in general, one can establish a practice however way they want, but I classically, in immunocompromised patients, I will use, that's the only time I personally use a 2-piece inflatable device, and again, we can talk about that at the Q&A session itself. This was a Adrienne mini Jupette graft at the time of penile prosthesis, so the authors here were looking at concurrent penile prostheses, and then they were using a 3-centimeter mini sling placed between the corporotomies. This is novel. It's not prime time just yet, but
1 minute. 1 minute.
Thank you very much. 86% had reduction or resolution of climacturia, and 88% reportedly had reduction of mild stress incontinence itself. Again, something that the DoD database and the VA database is very good. Nearly 13,000 men here looking at penile injuries with particularly urologic injury, so the incidence is about 5%. They more often will have urinary symptoms and sexual dysfunction itself, and more importantly, 3% of them are coded into a urologic arena itself. And then, more importantly, during the Iraqi operations and enduring freedom, for penile transplantation, 86 patients with severe penile injuries. So this is an emerging field as well in the level of trauma itself. Ejaculatory dysfunction, I'll finish off very quickly. You're looking at a oxytocin receptor antagonist, double-blind, placebo-controlled study, no serious adverse events, and we can talk about ejaculatory dysfunction, premature ejaculation in particular, because that seems to be more prevalent in younger men. Peyronie's disease, we're going to talk a lot about Peyronie's disease, but here they talked about the use of vacuum or traction device as therapy to injections or adjuncts to injections. Keep in mind, no improvements were noted itself. And then whole genome sequencing in a cohort of patients, family members who had Dupuytren's contractures and Peyronie's disease, and the new pathways of chromosomal rearrangement and GI epithelial maintenance was noted itself. And we're going to talk about calcified Peyronie's plaques extensively, and more importantly, looking at tissue constructs using non-human primate corpus cavernosum smooth muscle endothelial cells to use them on an acellular matrix, with the idea that using bioengineering principles, you can then use corporal constructs for patients with congenital or acquired disorders itself. So there's some cutting edge stuff evolving itself.
Yep. Thank you so much, very interesting. We will leave the question to the end because we have 55 minutes to discuss Q&A. So you can go ahead, Dr. Nehra, with the second talk, which will be erectile dysfunction, medical and surgical management.
Can I have my next presentation, please? Oh, got it. Okay. Medical and surgical therapies. Please keep me on cue and time here, so let's go quickly. Sorry. All right. I think I'm not going to spend too much time on workup, but I just want you to know, please, for all the residents here, please do a complete medical history, which includes comorbidities. From a men's health perspective, the sooner you establish databases, you're going to understand linearly what's going on with that particular patient over a period of time. And of course, physical examination, diagnostic tests, in particular glucose, looking at presence of anemia, renal dysfunction becomes very important, assessing the hormonal issues. In the United States, duplex ultrasound has become the diagnostic modality, non-invasive, and of course you can do a neurologic assessment by using penile vibratory stimulation itself. So clearly what you look at is, when did it start, risk factors, drugs, cardiovascular risk assessment, and I would recommend use of validated questionnaires and a IIEF using the 5-questionnaire SHIM score can easily be incorporated into a computerized analysis for obtaining a pertinent history itself. Physical examination, again, we talked about penile vibratory thresholds. These are slides that you can have for the association itself for resident education. You have poor visualization. You have vascular assessment. You have to look at carotids, femorals, popliteal pulses itself. And more importantly, here you do a detailed physical examination that includes not only penile but testicular assessments as well. And again, when applicable, testosterone levels and or prolactin, gonadotropins if testosterone is low itself. A hemoglobin A1C and a lipid profile if necessary. Specialized testing for ED is not required prior to instituting therapy, except I tend to use it quite a bit in my arm because in terms of clinical publications, I tend to want to be able to make that assessment early on. I always encourage the partner to be present, the spouse to be present. I get a much better history from the spouse than I do from the patient itself. and specialized testing is performed if it's going to alter the course of therapy itself over a period of time. So as I talked about, duplex ultrasounds, biophysiciometry, NPT testing can be used, but duplex ultrasounds are important. Caverosinometry and caverosonography, along with penile angiograms, only should be reserved in centers of excellence, and that's what the AUA guidelines. I happen to be the co-chair of the AUA guidelines with Bud Burnett. We're going to be presenting at the AUA the updated guidelines in May of 2018. So we hope to share that with you as well. For all residents in training, again, you have to redose during duplex ultrasounds to remove the anxiety or the issues related to adrenergic pathways. So to obtain corpus cavernosum smooth muscle relaxation, peak systolic velocities greater than 30, end diastolic velocity should be less than 3 to 5, and resistive indices of 0.8 or greater. That itself will give you a normal erection. In terms of therapies, I just have a list of all the therapies from the 60s to 70s, 80s, 90s, and 2000 and beyond. And again, you have to treat the comorbidities, you have to assess the cardiovascular risk as well, and more importantly, you have to appreciate that there's no incremental increase from the use of PDE5 inhibitors over a period of time. So testosterone usually starts to diminish after the age of 35, and it's often associated with ED itself. You have decreased energy levels, fatigue, etc., that you're all aware of. But more importantly, excuse me, you can have a decreased muscle mass and bone density that affects not only memory and overall cardiovascular health, and PDE5s may be less effective as well over a period of time. The therapeutic options include IM therapy. Thank you. I have it. Thank you. I have IM therapy. You can use topical therapy or testosterone pellets itself. And you can convert a potential non-responder to a responder itself using PDE5 inhibitors on low T after the T has been corrected. Treatments also include second-line therapies. We're going to be changing these first-line, second-line therapies, and third-line therapies for the guidelines coming up. I can share that with you. Just hang on. In about 6 months, you'll hear how we're changing that. The paradigm of management is going to change overall. So everybody knows about PDE5s extremely well. Dr. Rareborn talked about PDE5 use in BPH, lowering tract symptoms along with ED. Here we're talking about just in the field of ED, but basically just what you know, these are PDE5 inhibitors. For residents, again, there can be cross-reactivity with PDE6 in the retina, PDE11 in the muscle, heart, testes, and the pituitary, responsible for various side effects itself. So again, this is just a quick primer for the residents as well. As you know, endothelial cells producing nitric oxide, working through the guanylate cyclase mechanism where GTP gets converted to cyclic GMP, and that is where PDE5 inhibitors work for the residents. That's what's providing corpus cavernosum smooth muscle relaxation, initially tumescence, subsequent rigidity itself. So we know that sildenafil, vardenafil, tadalafil, levanafil are all selective and specific PDE5 inhibitors with an efficacy rate of about 50 to 60%. And they are much less effective in moderate to severe ED itself. And the adverse events, I think you all are extremely well aware of that, but I want to just look at specific adverse events here. The visual changes, particularly with sildenafil, muscle pain, predominantly with tadalafil, PDE6 retina, and PDE11 muscle, just for the residents again. Contraindicated, any patient who is on nitrates or has been on nitrates is contraindicated to the use of PDE5 inhibitors. And then drug-to-drug interactions, of course, with alpha blockers, With sildenafil, you have to separate based on half-life, separate by 4 hours. Tadalafil alpha blockers start at the lowest dose. Vardenafil again start at the lower dose itself. I'm going to move ahead on the mechanism of action because we're going to go to injection therapy as well. And if I can I go to the previous slide for a minute? Penile injection therapy, as you know, was evolved in the late 70s, early 80s, and this really evolved during one of the international meetings where a urologist self-injected himself on stage to show the effect of papaverin. Historically, we now have an FDA-approved prostaglandin E, or a lot of us tend to use trimix therapy. Trimix therapy for the sole reason because you work in papaverin, regitine, and prostaglandin through both two cyclic nucleotides, cyclic A and cyclic GMP. For the residents, again, it's very important. Studies have shown when you have a synergistic pathway that will produce less pain and a superior erection with trimix therapy in comparison to monotherapy, whether it's papaverin, whether it's regitine, or whether it's prostaglandin E itself. The disadvantages, of course, are that they can induce pain, they can induce fibrosis, they may induce priapism. That's why you always want to give the first dose trial in the office itself. And, as you will expect, a high dropout rate as well. Muse intraurethral suppositories used very less frequently. Pardon me?
You can make it full screen.
Okay,
with a slideshow.
I'll do that right now, and just.
Yeah, the right one. Yeah.
And we have, so I'll tell you, Muse therapy used extremely in a very, very small percentage of patients, predominantly because of intraurethral pain itself. That's the sole reason. Vacuum erection devices. I think vacuum erection devices are not here to promote erectogenic responses. I've already discussed with you, they can preserve penile length. I would highly recommend that. In patients who have Peyronie's disease, in particularly less than 30 degrees, you can use vacuum erection devices to obtain stretching. You can see some improvements. This is unpublished data. We're working on publishing it, but more importantly, the use of vacuum erection devices in small curvatures may be beneficial itself. Do not have them overinflate the device because you can have numbness or delayed or painful ejaculation. Prosthetics remain an ideal option, highest satisfaction rates for both patients and partners overall compared to all other therapies moving forward. In the US, we have malleables, 2-piece and 3-pieces, and a lot of us, as you know, who do a lot of these, ideally use 3-piece inflatable devices, except for, as I told you, my personal bias for transplant or HIV patients, I will only use immunocompromised patients, I will use a 2-piece inflatable penile prosthesis. So these are some of the devices. You are all extremely familiar with it. These are some of the indications. Again, I won't belabor this. This is well known. I'll go through surgical techniques. Penoscrotal, infrapubic. I was fortunate to be trained in both approaches, and I continue to use both approaches. I think they're extremely good to use. Here I'm going to show you a scrotal approach with a high scrotal incision itself. You're able to look and move the penis over after it's been catheterized itself, delineate, make a small incision, secure the incision with blunt hooks itself. The incision stabilized. You now use you're going to start to make a small corporotomy and dilate internally, both distally and proximally itself. Always stay lateral. If you stay lateral, for all the residents in training, you're not going to injure the urethra, you're not going to perforate the corpora itself moving forward. Again, you can use a combination of whatever dilators you want. Be comfortable with dilating. A frequent And this is an exam question. A frequent question is if you have changes in size from the right to the left side, as a surgeon, it doesn't happen. That means you have either perfed one side or the other side you have not dilated ideally, because they should be exactly the same. So that's something that needs to be addressed itself. You can use dilators and depths with various angles that are comfortable. And remember, always stay lateral. You can use mini corporotomies moving forward. Here, reservoirs. We've been trained to use a blind reservoir placement itself. It's very important. You can go through the external ring, hug the pubic bone, enter transversalis fascia, and you enter the perivesical space of Retzius itself. You don't have to tag the pump or PEX the pump in any way. Leave it in the most dependent position itself. Post-operatively, you can continue antibiotics for 3 to 5 days. Pain control, you've already seen one of the abstracts. You can modify that as well. Some used a closed suction drainage. I've never drained any of my patients itself. No strenuous activity or intercourse for about 6 weeks, standard wound care, scrotal support, and a short-term follow-up visit. I think everybody knows the pros and cons, so I won't belabor the issues of pros and cons of prenatal prostheses itself. You minimize the risk of infection, have the patient be shaved in the operating room. Perioperative use of antibiotics, limit the OR traffic, meticulous aseptic techniques, avoid urethral contamination, constant irrigation intraoperatively, and minimize skin contact with the IPP components itself. In terms of infections, my personal bias is remove cultures intraoperatively and remove the device completely. Trust me, you'll come back in 2 to 3 months and you'll replace a brand new device, plus the presence of cultures. If in my hands, if I get an infection, I know it's not a subclinical infection. I know it's a significant infection based on colony counts that we've done in the past. So I explant the device, come back in about 8 to 10 weeks, and replace it with an entirely new device itself. I don't use an intermediate malleable device. Some authors do. Penile rehabilitation post radical prostatectomy, its role has been looked at critically, but I can share with you there's no standardized regimens, and the data for penile rehabilitation has not been ideal, to be candid with you. I think it's very important that you do institute a good PD5 program, and if that program is not working well for the patient based on a bilateral comorbidity, bilateral nerve sparing comorbidities, unilateral with comorbidities, or non-nerve sparing, you need to move very aggressively with that patient to make sure that penile length is maintained over time, because when you have lost bilateral neural pathways, you basically are now rendering that patient to a tunical apoptosis, which is going to change penile length over a period of time. I think you know the pathophysiology of ED following radical prostatectomies itself. As I said, the earlier you institute therapy, we at Mass General start the patient on a PDE5 inhibitor a week before his surgery, not to get an erection, but to have them make sure that adverse events are not there, and then you start the protocol itself following his surgery itself. And again, numerous pathways of intracavernosal therapies along with PDE5, vacuum erection devices have been utilized. Poor prognostic factors, I think everybody's aware of. If after 6 months you have a prostatectomy, you're not getting erections, you're getting indication that that's not going to be handled very well. Age greater than 60, if there's a high dose of trimix requirements and the presence of one or greater vascular comorbidities, those are all pathways why you think that you'd want to be aggressive to move the patient to maybe a penile implant itself.
Thank you, Dr. Nehru. We'll proceed with the third presentation, ED and as a marker of cardiovascular disease.
This is a very near and dear presentation for me. I've been involved with the Princeton Consensus Panel for a long time, and it's a privilege to share some of this data. I think it's very important. When the Princeton Consensus Panel was conceived, now 18 years ago, it was really looking at sexual activity, cardiovascular risk because of PDE5 inhibitors, which evolved at that particular time. And we really wanted to come out with management of ED with significant cardiac risk factors itself. The second Princeton Consensus Panel went a step further. They evaluated the link between cardiovascular disease, ED. They assessed the risk of sexual activity in patients with cardiovascular disease. They evaluated the cardiac safety of current ED therapies. They considered the potential cardiovascular benefits of PDE5 inhibitors, and overall looked at EF and cardiovascular benefits of lifestyle change itself. The Princeton Consensus Panel really looked at, they wanted to update the panel from 2005, recognize predictive value of vasculogenic ED in assigning cardiovascular risk in men of all ages. And this is where men's health becomes a very important paradigm moving forward. Develop an approach for cardiovascular risk assessment in the younger ED patient with no known cardiovascular disease. Examine the role of testosterone in EF and cardiovascular health and the utilization of testosterone therapy. Clinicians should assess sexual function as part of an initial cardiovascular evaluation for all men regardless of known risk factors and cardiovascular disease, and the exercise tolerance should be established prior to initiating ED therapy in any patient, regardless of cardiovascular risk itself. So moving forward, we went ahead and wanted to really explore the link between vascular health, erectile function, or dysfunction, and hypogonadism itself, and that really is the why. Because you can see the magnitude of the problem, and here it is. You saw the number of population, 170 million patients that are going to be affected from a conservative analysis. And why this became important is because if you look at the pathologic issues, conditions, or risk, look at prevalence of ED on one hand, look at the condition on your left-hand panel, and what you see is age greater than 40, ED prevalence. Type 2 diabetes, hypertension, coronary artery disease, look at the prevalences of ED. Heart failure, 75% of them have ED prevalence rates. Obesity, hyperlipidemia, smoking, which I know is a big issue here in the kingdom. You have increased prevalence itself, and the use of medications overall as well. What we do know is that when ED and mortality was evaluated in a 15-year follow-up, at baseline, ED was absent in over 1,000 men, was present in 338 men. This is a study by Andrea Rujo. So what happened is they went ahead and completely looked at the data of 371 men of the 431 men who had died. If they looked at all-cause mortality, if you looked at the hazard ratio, it was 1.26, and the cardiovascular mortality hazard ratio was 1.43, and that's significant for men who had a 15-year follow-up over a particular time. If we look at the plaque burden, again, 132 men, looking at IEF correlations, 30% of them had single vessel disease, 21% had two vessel disease, and 27% had three vessel disease itself. And more importantly, as we were discussing prior to the presentation, 58% of men with ED predated the risk or the diagnosis of coronary artery disease itself. Another study that looked at cardiovascular events in patients with ED at high risk using ACE inhibitors or ramipril or both. And here you can see that sexual dysfunction was a potent predictor of all-cause death and the composite of cardiovascular death, MIs, stroke, and heart failure in men with cardiovascular dysfunction itself. So in summary here, very nice by Dr. Bohm, what he said is that thus erectile dysfunction represents in line 4 an early symptom of endothelial dysfunction and atherosclerosis, and patients with ED are at particularly high risk for cardiovascular risk. The identification of these patients with ED offers an opportunity for early risk-adjusted treatment with the goal of further reducing future cardiovascular events itself. All right, so can we use erectile dysfunction as a means to detect cardiovascular disease, or conversely, can we use erectile dysfunction as a means to prevent cardiovascular disease? And this is why men's health is so important. Again, look at the penile vasculature, 1 to 2 millimeters. Look at the coronary vasculature. And if we go on, the smaller the diameter, the penis is a vascular organ, very sensitive to NO levels and oxidative stress, and the high endothelial content is why it becomes an early manifestation of vascular health and future cardiovascular disease itself. So in the PCPT trial, that was Ian Thompson's data, it's a landmark study in 2005. They looked at men 55 or greater, randomized to the placebo group in the PCPT trial. Over 9,000 men were evaluated every 3 months for ED and cardiovascular disease between 1994 and 2003. And here, among the 4,000 men without ED or cardiovascular disease at study entry, so in 1994 they had nothing, 57% reported an ED incident after 5 years and 65% at 7 years. So more importantly, in this landmark publication, ED was associated with the development of future cardiovascular disease with a hazard ratio of 1.45 itself. In the Krimkin study, again, hazard ratio in men, if you look at the second to last bullet point, severe ED, hazard ratio of 3.8 itself. And if you look at just ED, the hazard ratio is 2.0. So the cumulative incidence of ED of cardiovascular disease by ED status, you look at unadjusted, and on the right-hand panel, adjusted for baseline risk score. And you will appreciate that there's significant penile rigidity, there's reduced penile rigidity, or there's no ED. And if you look at the adjusted levels, you're able to see the cumulative incidence by ED status itself over a period of time. The Massachusetts male aging study, and this was Andre Arujo again, looked at men who were 40 to 70 and over 1,700 men, followed for 12 years for the development of cardiovascular disease. He noted 261 cardiovascular events over time. And if you look at the age-adjusted model in the same publication, 1.42, multivariate adjusted, 1.41, and adjusted for age and Framingham risk score was 1.40 itself. What happens if there's confirmation that ED increases the risk of cardiovascular disease in men with diabetes? So if you have now diabetes added on, there's an augmented risk of cardiovascular disease and vascular health over a period of time. And at 4 years, on the fourth bullet point, at 4 years, cardiovascular incidence was 1.6-fold increase in men with ED versus no ED itself. And keep in mind, a subtle finding for all the residents again in training, microalbuminuria, don't forget to check that periodically because it is associated with a strong risk, and this can be a board question for future residents in training as well. The relationship between ED and silent MI in men was looked at in type 2 diabetic patients. And I just want you to zero into the last 2 bullet points here. What became important is ED can be a silent marker of coronary artery disease in type 2 diabetic patients and indicates the potential value of stress tests for risk assessment itself. So you're going to stress them into low, intermediate risk, or high risk itself over a period of time. And looking at overall risks at baseline, at 10-year follow-ups in 1,400 men, you're able to see ED at baseline versus no ED at baseline. Looking at the decades of range, you're able to see that future coronary events will be predicted in this particular subpopulation with a hazard ratio in the younger population in particular of 2.7. In the 50 to 59, it drops to 1.3, still important, and then 60 to 69 is 1.5. So these are the 3 decades of age range that become extremely important, where a strong relationship of erectile dysfunction, cardiovascular disease, particularly in young men, is extremely irrelevant itself. So in terms of a data study itself, I know I'm throwing a lot of data at you, but I want to share with you that this is just not one study, it's multiple global studies that have looked at it. Looked at cardiovascular events doubled in men subsequent to ED with a relative risk ratio of 2.2, and was noted to have a 12.3% increase in 5 years to 37% at 10 years, 76% at 15 years, suggesting that there's a 7-fold increase in men who are less than 40 years of age as a predictor of subsequent cardiovascular events over time. And this is, again, you can see the incident rate ratio and the confidence interval over time for the various decades that are presented here as well. So let me just move on very quickly to windows of opportunity, and you can see where I've highlighted the various things. So the interval from manifestation of ED, 12 years, 11.9. You can see the cumulative incidence. If you look at the interval here, from 5.1 to 10, 37. 15 goes to 90.6 cumulative incidence. That's a very high incidence over a period of time from the initial manifestation, the interval from the initial manifestation itself. So as we start to wind down this particular presentation, it becomes important that the hypothesis is that ED is indeed a sentinel event for cardiovascular disease, silent, futuristic, with risk factors, who in particularly type 2 diabetes itself. Occlusive disease should manifest earlier in the microvasculature than larger vessels, and there's a high co-prevalence itself. Overlooking ED in men is a significant missed opportunity, since cardiovascular disease is a leading cause of death in the developed world and in the developing world. I can tell you, India, where I originated my career in, it is a hotbed. Delhi is a hotbed, #1 city in the world for diabetes prevalence. Genetic, environmental, dietary. These are the 3 risk factors, and I can share with you that is a huge database that I've recommended that they institute to look into men's health over there, and they are doing that. Similarly, I think the Kingdom has a unique approach, because with a population, I believe 70% who are less than 30 years of age, I think it's very important if we screen them early, you're actually conserving or preserving healthcare dollars and educating them towards a healthy lifestyle in the future itself, merely by the presence or absence of ED. So can ED be used to reclassify cardiovascular risk? Absolutely, and you're seeing the 10-year cardiovascular probability after a inclusion of ED in the diagnosis. So you can see that in less than 5%, the cardiovascular probability is 27%, but as you start to increase the probability scores here, you're able to see the 10-year probability does go up after you include ED itself. As I start to summarize this, you can see that ED and hypogonadism can also be a major issue. This is not a talk we can give today just because of time constraints, but I think one needs to talk about testosterone therapy in the presence of ED and cardiovascular risk, and maybe some of the questions and answers we can certainly elaborate on this further, but keep in mind that ED, ischemic heart disease, impaired vasodilatation, atherosclerosis, endothelial dysfunction, oxidative stress, altered protein explosion in the presence of hypertension, obesity, type 2s, and dyslipidemias become a substantial risk factors in these men. So,
Thank you, Dr. Nehru. We'll proceed to the last talk about Peyronie's disease, medical and surgical management, and by then we'll start the case discussion and questions.
are we pretty much on time?
5 minutes late.
5 minutes late, okay. Well, try to steer everything. So, you know, I presented the Peyronie's disease guidelines in 2016 at the AUA as the co-chair. And what's become important is we know that Peyronie's disease is an acquired disorder. We know its prevalence rates are increasing in all parts of the world. So without any delay, I'll tell you this is what a normal tunical anatomy looks like. You can see the tunica albuginea, the cavernosal spaces with the sinusoids, the fibromuscular strands that basically go across the tunica that provide the ability for penile rigidity penetration to occur over time. So Peyronie's disease is characterized by penile bending. It's usually occurred by an inflammatory response with or without trauma, with or without a hematoma. It is usually a plaque formation. 3 typical scenarios for Peyronie's disease: asymptomatic plaque with ability to continue intercourse, penile bending and erection, preventing intercourse, and finally penile bending and concomitant erectile dysfunction itself. This is what happens pathophysiologically. Once you have inflammation, disruption of the microvasculature, you have recruitment of macrophages, you have these inflammatory cells that are continuously elaborating cytokines, elastase, along with chemotactic factors that result in what's happening on the other side at the microvasculature, tissue proteins including fibrinogen, fibrin deposition, collagen synthesis, pathologic fibrosis. If it's really worse, we don't see it very often. In the past we did, ossification as well. And you can have, when you have fibrin deposition, you can have clearing or resolution. You and I both know that we have now an FDA approved product. Does it resolve everything? We can talk about it during the questions and answers discussion. But more importantly, in patients, particularly when they have collagenase inhibition, that results in pathologic fibrosis itself. So, in summary, with history, it's very important. Please make an assessment of type of trauma, duration of symptoms and curvature. Is it stable? Is it progressive? What are the associated changes? Sensation, length, curvature, girth, EF function. Is there a history of depression or not? Continuing on history, very important. Are they able to complete intercourse or not? Are there any rheumatologic conditions, rheumatoid arthritis, Dupuytren's contracture? Are there any HLA subtypes that they may be aware of? Associated curvatures. This is extremely important to ask because you will confirm this as you do the duplex ultrasounds in conjunction with ICI in the office. Is it a uniplanar or a multiplanar curvature itself? So single plane or multiplane? Is it stable or is it unstable curvature? Is there concomitant wasting or deformity, and the amount of the curvature itself? It's always wise to get a lower urinary tract history for all the residents again, and of course, presence of diabetes, hypertension, cardiovascular disease as well. On physical examination, palpate where the plaque is, measure its size, identify its location. Is it creating a hinge effect or not? Is it associated with narrowing or a bottleneck deformity? And look at the penile length, measure it, document it both in the flaccid and the stretched components, and look at any sensory changes, and I'll share with you why. Any surgical procedures that you do, you want to be able to go back and appropriately document what happened preoperatively, and that's why we get sensory penile vibratory stimulation to really make an assessment about the sensory changes itself. Would highly recommend the use of duplex Doppler ultrasounds. Redosing, trimix, monotherapy with PG1, whatever you're comfortable with the use of photographs is very important. Identifying the hinge effects, again, waist deformity, and a uni or a multiplanar deformity as well. So this is a ultrasound in the longitudinal and transverse view of the corpora cavernosa, demonstrating fibrosis itself, and you're able to see the arrows, and the dense fibrous plaque that basically extends down now into the cavernosal tissue. Why this is important is because here, if you start to use Clostridium histolyticum, it's not going to improve anything because this is already infiltrating the corpora cavernosa. So you're going from the tunicle to the cavernosal space. So in a way, you know what you have to do here long term to identify and correct this plaque itself. This is a calcified plaque, on the other hand, that involves the tunica albuginea and covers the cavernosal tissues itself. So medical management, I'm going to run through medical management very quickly, and why? Because there's nothing new, and we did a exhaustive review of the medical management for Peyronie's disease as I presented in 2016 at the AUA for the guidelines, and those were published as well. I can share with you, while it's always good to look at medical options, classically they should be reserved in patients who have an initial evaluation with a diagnosis of Peyronie's of less than 12 months and or an unstable deformity of less than 3 months. And you really want to have a candid discussion with them. Are there progressive changes? Are there associated changes in sensation? Is the curvature stable? Is it progressive? Is it worsening? And the quality of erection. So these are important things that you want to be able to use. Currently, only 21 randomized controlled trials for Peyronie's disease, and these RCTs deal only with medical management. None deal with surgical management itself. I'm going to run through the medical management very quickly because none of these therapies were effective itself. And I just want you to scroll down to the last bullet point. Look at this, no significant improvement in pain, curvature, plaque size compared to placebo. Intralesional, topical, electromotive verapamil has not been shown to be any effective in the management of Peyronie's disease itself. Intralesional interferon, I was a co-author. Wayne Hellstrom was a primary author here. And if you just go on to the last bullet point, intralesional interferon 2B injection therapy alone or in combination with vitamin E does not appear to be clinically effective compared to oral vitamin itself. Okay, moving on, Dr. Pfluger looked at superoxide dismutase as well, and what he said is it is only appropriate for the very early painful symptoms. This is a single author, And this is, again, looking at just 4-week data itself. Pataba, no role at all. Trust me, colchicine, absolutely no role. And I'm sharing these slides because I want you to be aware of all the medical options that have been published, looked at, but none of these have really shown any effectiveness. Verapamil plus oral carnitine or tamoxifen was looked at, and again, nothing that was substantial itself. Tamoxifen was looked at it. You know, idiopathic retroperitoneal fibrosis, tamoxifen has shown some efficacy. In Peyronie's, on the other hand, it has not. There's some data that's being looked at shockwave lithotripsy and intralesional therapy itself, and the data is still coming out. I'm not saying that it's going to be ready for prime time, but it remains to be seen what's going to happen to shockwave therapy itself. I think this is where the bang for the buck is. In a patient who has stable disease, loss of penile length, presence of a curvature that's either uniplanar or biplanar, you want to be able to offer them various surgical options. So we're going to talk about the use of plication procedures. We're going to talk about graft procedures itself. It's fair to say tunical incising procedures give a better long-term results than imbrication procedures. So when I say tunical incision, I classically will just make an incision in the outer layer of the tunica albuginea. I will not go through and through because invariably in men that creates a hematoma postoperatively, and I will use my plications in such a manner where I can go ahead and correct that after I've done my tunical incision over a period of time. Additional indications include for complex deformities, hourglass deformities, patients who have lost some penile length and or who've preserved penile length, moderate to severe curvature, and patients who have normal erectile function. Those are indications for looking at grafts or for tunical incision and procedures itself over time. In terms of grafts, synthetic, autologous, prepackaged biological are used, and indications here in terms of an implant are patients with Peyronie's disease with ED, patients who have hourglass deformities, post-surgery curvature resolution has been noted. What you can do, use of penile prostheses, and I'll show you this in future slides, is that you can use penile molding extremely well with the use of penile prostheses to correct the curvature completely intraoperatively during the first sitting itself. So again, your objectives should be measurement of penile length, sensory sensation measurements, resolution of the curvature, looking at intercourse success rates, psychosexual effects, and revision surgery if needed itself. And in terms of plications, you have a Nesbitt, you can do a Yeshia procedure, you can use the saphenous vein or the cyst graft, or you can use a penile prosthesis plus or minus remodeling itself. So I'm going to go through a couple of cases, and we have some more cases coming up later on. This is a 19-year-old collegiate male with a ventral curvature. So this is not Peyronie's disease, mind you. This is congenital in this particular patient. He had normal erectile function. So what happened is, why did he develop this? Because there is discordance in the corporal lengths in this particular patient, and that's why he's getting a ventral cordee itself. He stated he had difficult penetration and partner discomfort. You look at treatment options. He has normal erectile function. This is an ideal patient who will be helped with a Nesbitt plication. Intraoperative erection is performed. He's got a ventral curvature, so you have to mobilize the neurovascular bundle. This is your site of plication. You put in a row of plication sutures coming all the way across from about 10 o'clock to 2 o'clock itself. You may require a second distal plication as well. It's not a big deal. And more importantly, you want to be able to show complete resolution of the curvature itself. Second patient, 52-year-old, IAEF of 23, normal libido. He has severe Peyronie's disease for greater than 4 years, no intercourse for 2 years, in a stable relationship. He's very depressed because of his curvature and presence of Peyronie's disease, and the duplex ultrasound, normal parameters itself. So this is what he on duplex ultrasound is what he has. You can see the amount of curvature that is present. Clearly, he's lost penile length as well. And this is what it looks with an artificial erection, a cobra head deformity over this thing. So if you look at it, what we have done here is we've evaluated a large series of patients. And here you can see the urethra, the tunica, and more importantly, the fibrous strands secondary to the Peyronie's disease that are afflicting this patient itself. And if you go on, you will go ahead. This is a patient who he's 52, normal erectile function by duplex ultrasound. He's got a substantial curvature. He opted to have a graft. He did not want to have any further loss of penile length, so application was out of the window. He wanted to go with a graft itself. So it's an extensive graft that you want to do. So as you lay down, you look at it, and this is an extensive graft. You mobilize the urethra completely, free it up, and then you put in the cyst graft. Always oversize the cyst graft by about 10%. Dermal grafts, 30%, but I would not recommend dermal grafts. Cyst grafts are probably the most appropriate way to go, and these by 4x4. And this is what it looked following the cyst graft itself. And you can see concomitantly there were some plication sutures that were placed as well to result in curvature. He actually had a very good outcome long term. We placed him on vacuum erection device therapy. He had a very, very good outcome long term. I'll present to you cases that are horrific, cases that are excellent, but our main objective has always been outcomes. This is a 56-year-old patient with a 6-year history of a penile curvature. It is currently stable. He's got severe penile shortening. He's got normal sensation. His duplex ultrasound is normal. So from a resident perspective, keep in mind, he's got severe penile shortening. Your options are dramatically limited here. And you can see on a lateral view, he's lost substantial penile length itself. And you can see the curvature. So options here are extremely limited. And as you go through all the options with the patient, he chose that he wanted to do a penile implant itself. So as we place the implant, you can see the curvature still present. And then this is where the technique of molding. Once you place the penile implant, use your clamps, rubber shot clamps on the exit tubings with the device inflated to only 70 to 80%, no more. Don't make it 100% inflated. With that, mold the penis in increments by 15 seconds. You will require 2 or 3 penile moldings, and that's the end result. You can see with the device inflated his overall outcome itself. Yeah, he's got penile shortening. That's not the objective, but you've resolved his substantial curvature where he was not able to penetrate at all. And finally, on the last slide, I think it's a very appropriate algorithm. We also came up with an algorithm for the guidelines itself, published in Journal of Urology. But really here, you want to be able to look at, is the disease progressive? Is it quiescent? You can look at medical options, but there's no medical treatment that's really out there except for Clostridium histolyticum. And you look at surgical options, whether it's tunical lengthening or tunical shortening. Look at penile prostheses, with or without molding, with or without grafts. And then these are some of the algorithmic pathways for Peyronie's disease.
Excellent. Thank you, Dr. Mehra, for the thorough presentation. I know we're short of time, but you gave a nice, actually, overview on the andrological and sexual aspects of the. We're still missing the infertility, but hopefully next time. So the floor is open for questions. We have 50 minutes to accomplish this. So we have questions, and then we have cases. Give a mic.
Yeah, so I can tell you, I'm relatively conservative, and I would like to get better data. So I know the proposed mechanism of ESWL therapy that they're saying. They talk about neovascularization. They talk about recruitment of microvasculature in this, but we have very, very limited data in North America, I'll be honest with you. And that's one of the reasons I didn't present that. The data that predominantly came out, as you know, from Europe. And I think it's fair to say, should it be offered as a first-line therapy? I don't know the answer to that today. Maybe 2 or 3 years after we have 5-year data, we can truly critically assess this, because I think that's where you want to be. I think it's wise, if you're going to institute it, to do it under a research protocol. I think that's very wise with IRB approval, because I think that's one way you will objectively make an appropriate assessment on its efficacy itself long term.
Excellent. Professor Sian.
Thank you, sir.
And I have two questions. One is regarding the erectile dysfunction patient and the use of duplex ultrasound. I don't know if duplex ultrasound will change your management in any way after you have the physical and history and all that kind of stuff. That's one thing. If it, maybe for research purposes, it's nice. It's nice to do.
Okay.
That's one thing I'm asking. The other, in the medical treatment of Peyronie's disease, I would like to separate between the active phase of Peyronie, and then some medications might be indicated at that period until the pain goes away. Then the rest of the medications, as you said, they are not useful in the stable situation. So what are your thoughts about this?
Okay, on the first question that talked about, I'm sorry, your first state.
Duplex ultrasound
Duplex.
and ED.
So let me tell you why duplex I think is important. Two ways. In North America, we live in a very litigious environment. All right, that's number one. It's always wise to document preoperatively what the sexual function, vascular status is. So for us, it becomes very important. Number two, I think I'm able to pick up certain patients who have cavernosal arterial insufficiency or veno-occlusive dysfunction who may be at a higher risk for cardiovascular disease. So those, I can tell you, are two aspects. The third indication for duplex, and I didn't go into indications for duplex, is in the arena of trauma. Okay? I think it's wise if you have a tunical, for all the residents again, if you have a tunical injury, if you have and you have a concomitant hematoma, just put a duplex probe right there. You'll find out exactly where the injury is. If the patient is presenting acutely, I would take him to the OR and correct it. On the other hand, if he's a late manifestation, you may want to observe that, letting him know that he may develop a calcific density over there and curvature itself. So that's on the ultrasound aspect, okay? On your second question,
Peyronie's disease, the active phase,
yeah. So I think that's a very fair assessment, what you are stating. The challenge is in the acute or active phase, you can only use certain medications. You know the product label on the Clostridium histolyticum is you can't use it in the very acute phase itself, all right? So for us, I think a combination of indomethacin, Advil, anti-inflammatories, Motrin are probably ideal in that. Can you use a cord block? Absolutely, you can. But more importantly, I think they're limited in what you can do. And classically, you also know that in tertiary centers, we don't get the patients who come in acutely with the acute discomfort unless they are a direct referral by the patient itself. So those are the limitations.
Thank you. Excellent. Dr. Nehra, I have two questions.
Yes, sir.
It's regarding infections in the area of penile prosthesis. The first one is, I see the paradigm is changing now. You know, we started to be more patient when it comes to infection. So when the patient comes with an infection, and he has what looks like a superficial infection in a patient who had a 3 pieces antibiotic impregnated prosthesis implant. You know, I take them slowly now. We used to book them second day for removal, but now based on AUA actually abstracts from, I forget the first author. So I give them antibiotic. I succeed with 2 patients actually, providing that the patient does not have an malleable. He has 3 pieces. And I do whether MRI or any imaging that rules out any deep collections.
I agree. So I think that's you're responding yourself. In a patient who has a low indolent, those are the Morganellas, those are the typical fungal infections, okay? You need to be still aggressive with management using an antibiotic. On the other hand, there are patients, and I was pretty specific, who have tethering of the scrotal skin, loss of scrotal rugae, who have elevated white counts. You kind of know that they are prime time to have a removal itself. So there's a subset of patients that can move along, but a diagnostic modality, I think MRI, and we publish on that, is very integral in the overall evaluation and assessment.
That's very good. Dr. Walid?
Yes, sir.
Are you doing hemoglobin A1C to make sure that how control the diabetes, or you do?
Great question. Great question. So I told you that I'm very, very conservative. I will not operate on a patient with a hemoglobin A1C of 7. All right, I won't. I will only operate if his hemoglobin A1C is 6 to 6.5. It's a carte blanche rule. Why? I limit my rate of infections. I mean, my rate of infections, knock on wood, are extremely, extremely low. They're probably less than 0.2, they're 0.25%. All right, but I'm ultra cautious, and in the operating room, I am so anal that I have a dedicated team. I limit traffic, not touch the skin once the incision's been made. All standards of care that we're used to, but you have to be, in this particular instance, literally on the side of a obsessive compulsive surgeon to be able to get the ideal response that you want for the patient itself. So in your question, absolutely right, great, this thing. Anytime the risk of infection for all the residents in training again goes up quadruple fold if you if you're operating on a patient with a hemoglobin A1C of 7.5 and tenfold with a hemoglobin A1C of 9. So those are some of the facts, and that's why you want to be able to limit infections by controlling their hemoglobin A1C.
Yeah, Dr. Nehra, I'm afraid that if we become very strict on the hemoglobin A1C of 7, that will not be working on process anymore. I'll tell you why, because really in some patients, you know, just this is real life. No, see, I don't have a study on this, but I've done cases where hemoglobin A1C, I just could not get it below 8 or below 9. I sent them to endocrinologist. I waited 6 months on them, but then I just went ahead and put 3 pieces. Thanks
were
God,
okay.
they did not have the infection.
So clearly you're doing something right intraoperatively, where you're not introducing any infection.
Right.
You're obviously doing something correct, but keep in mind, we work in a very litigious environment. So if I was to operate on a patient of a 7.5 or 8 hemoglobin A1, I'm going to be there's going to be a prosecution attorney who's going to come in and say, Dr. Dara, you've published studies on patients requiring hemoglobin A1Cs to be evaluated and brought down. Why would you be operating on this patient? So keep in mind, I'm talking about North American data itself.
Right. Dr. Sultan?
with the hemoglobin A1C is high, is not contraindicated to do the operation unless you are following the good, for non-touch technique and antibiotics, continuous irrigations, and all this one. So I think that as Dr. Naif is, we working here with a lot of patients with non-controlled diabetes mellitus, and fortunately, all of them will succeed.
That's excellent that you've done that. So keep in mind, Steve Wilson is been great in the area of prostheses. He's also a cowboy to a large extent, and Steve would not mind me saying that to him as well. From where we stand in terms of resident education, maintaining standards. I'm just giving you my perspective from a very conservative pathway. And I work in an integrated pattern, integrated with cardiology and endocrinology when I was at Mayo and currently at Mass General. So I work through a very diligent process. And part of my rationale also is, if they are going to get an implant, I want them to see the challenges of a healthy lifestyle. Okay, or a healthier lifestyle.
Right.
So if we're going to be doing something for them that's going to be providing a great benefit to them from a penile rehabilitation, sexual performance level, overcoming depression, they have to work towards getting themselves, and this is part of the challenge in men's health, how you overcome these hurdles.
Okay. Right.
Do you think controlled blood sugar will improve maybe at the time dysfunction, and some of them they will not need? They will be helped with the injection or
So that's another very good question. So the studies in the past have shown, once you initiate a moderate to severe ED, controlling blood sugar better will not allow them to get into a milder ED status, because physiologically and pathophysiologically what you have is you have corporal fibrosis that is now initiated in the corpora cavernosa. So the smooth muscle has now been replaced by fibrosis, and it's typically type 1 and type 3 collagen. And when that happens, it becomes an irreversible process.
Excellent.
Sir.
We have more. Dr. Fayed, go ahead.
Well, I don't have a question, but it's rather a comment that reinforces a very important point that you mentioned, which is the seldomly discussed points in intraoperative management, having a dedicated team and an anesthetist who knows what you're doing, limiting the flow of traffic into the outside of the OR. I think this is very overlooked, I think, especially for a young urologist or an andrologist who's just starting his practice in an institute that is not a center of excellence. So I think many a times you find that the operative time is lengthened because those who are around the andrologist are not quite aware of what's going on. So this is something that is not usually discussed, but it's it's a very important aspect of the sort of the paradigm of the entire matter with regards to inserting a penile implant.
So just if I have 1 minute, in 1997, I was a young surgeon at Mayo, and I got 3 infections. So I was talking to Hamid. We have a mentoring system for 4 months with residents who rotate. I got 3 infections in the same 4 months. Very rare. So I actually halted my procedures for about 2 weeks. I reviewed all the data, all the personnel. I got everybody cultured, nasal swabs, etc., to make sure that we had not broken through any barriers that may have predisposed the patient, and we didn't. Those were unexplained. As I said, my infection rates are extremely low, but I'm also very meticulous in what we do. But so I go to the other extreme where I actually want to show or prove that we weren't as a group. So I had the nursing staff come in, the anesthesiologist come in, the resident come in, and any circulating nurse, we each, including myself, we all did swabs, etc. And we didn't, the incidence was of infection, and that short time frame was not initiated by us, but there was obviously some breakthrough that did happen. Yes, sir.
Yeah, I just want to caution against downplaying the importance of blood sugar control prior to prosthesis insertion. We do have data, our local data, that show are consistent with what Dr. Nera mentioned, that the infection rates are higher the higher the hemoglobin A1C level is. And the cutoff in the local study was around 8.5. So what Naif said was particular. He said that he tried and he was not able to have the patient bring down their blood sugar. So I think we should make an effort. We should have our patients take ownership of their health and make sure that they put in every effort to bring their blood sugar down before deciding on proceeding with a high hemoglobin A1C level. Thank you.
Yeah, and Naif, in those patients also, you know, nowadays insulin pumps are there for stricter controls. I always get dietetics involved because some of these patients, you and I both know that they're going to cheat on their food.
Yep.
So it's just some of the pathways, what you wanted.
Yep. So I just have one question, then we'll go to the discussion. Okay. You know, it's more of a philosophical, medical, legal issue. You know, we encounter patients who are getting to their 3rd wife, 4th wife, they're elderly, they are all diagnosed with poor risk cardiac events. So they're still insisting on the prosthesis, despite the fact that the pre-anesthesia clinic tell them, you are high risk, and they are ready to sign the consent for that. And some of them, even the anesthetist refuses to anesthetize them, and you know, we opt maybe for local anesthesia. I'm sure that everybody encountered these patients in our society.
Sure.
So my question is, do you think the prosthesis itself makes the risk, or the intercourse later on that makes them to die during the intercourse? So is that's you know, more of so would you go for?
So I'll answer that question. During the presentations, I didn't present this data. At the age of 70 or above, the frequency of intercourse episodes is 0.7 times a month. Okay.
That's for North America, maybe.
Okay, granted. Very well said. That's the data from North America. You're absolutely correct. Here, with a younger spouse, absolutely the incidence may be higher. I agree with you, but I think you're not going to initiate a cardiac event by strenuous exercise. I think they're not going to go through a significant exercise regimen. There's going to be a rate limiting step themselves, so I don't think it's a contraindication at all.
Okay. Makes sense.
But I think you need to follow the right principles of a good cardiac workup, and more importantly, a good consent form.
Yeah. Yeah, please.
10, 15 years ago, there was a lot of this in Venus League.
Yes, yes, yes. Yeah. Yeah, I'm sorry. I'm responsible for that getting out of the way. In 1995, I presented what I think is probably a substantial contribution to the field of sexual dysfunction, where we actually showed what happens in venous leakage prospectively done. And subsequently, we actually measured the collagen and the corporal smooth muscle content in these patients. And essentially what's happening is, during the era where we were doing cavernosograms, these patients had diffuse leaks. That's the problem. So when you get into a situation of a diffuse leak, a lot of us tried early on to see what happens when you get diffuse leaks. They don't recover. They recover at best for a few months. That's it. They progressively become, why? Because their intrinsic smooth muscle content to collagen ratio is altered. So I think I won the best prize at the AUA for that publication. On the other hand, I think it's very important, and you answer what to do. When you have a site, so in diffuse, it's very clear, implant. If they can't be captured by injections, implant. If in a young male who has site-specific leak, single site, under investigational IRB-approved protocols, in centers of excellence, you can probably perform a venous ligation surgery, with the idea that these are probably traumatic. But they have only a specific site leak. So that's what is very important here. I mean, Tom Liu, Irwin, Jake Rafer, myself, there were about 2 other centers looked at that. Wayne did not. And we did not, once you get into a diffuse situation, it's out of the ballpark.
Excellent. So we have 30 minutes for the case discussion. I just have a small announcement that we are doing our 3rd KFSH reproductive and sexual medicine meeting, which will be after 24 days from now. And this will be thorough, 2 days. First day will be live surgery on augmentation, penoplasty, difficult prosthesis. Second day will be state-of-the-art lecture. So, just to be more thorough. So you're most welcome. It will be here at King Faisal. Please go ahead with the.
All right, sir. How do you want to deal with cases? Should I go through them? I want it to be interactive.
We'll make it interactive. So if you want to present it, then we can.
All right. So I think it's very important. We see, and I said, increasing prevalence of rates of men who are diagnosed with Peyronie's disease, and collagenase Clostridium histolyticum was introduced. Urologists were utilized. So I think it's very important to say it's increasingly difficult to determine which men are appropriate candidates for treatment, which treatment approaches are the best, what are the key post-treatment considerations. All right. So I have 3 clinical scenarios here. Simple Peyronie's disease, complicated with preserved erectile function, and Peyronie's disease with erectile dysfunction. All right, here we go. Case number 1. Who wants to take this challenge on? Hamid, where are you? Perfect. You're on. You're in R5. Perfect. I remember. So 45 degrees dorsal curvature. No secondary deformity. Normal erectile function. He has a palpable, non-calcified dorsal plaque. What else would you like to know?
Yes.
I probably would want to know how long he's had the curvature for.
Yep.
Okay, I think that's
Was it stable or non-stable?
Exactly.
For how long?
exactly. All right. So in this particular patient, what treatment offer would you approach in a stable patient with simple Peyronie's disease? You have 5 choices.
I wouldn't go for the last 3 choices since they are invasive and the patient is having good erectile function and
Okay.
an acceptable amount of curvature.
Excellent. Excellent.
So, since the literature does not support the intralesional injections, I would start with a stretch therapy.
You want to start with stretching therapy. And okay, what do you use for stretch therapy, or what have you seen used for stretching therapy?
Honestly, none, but I think a vacuum suction would be a nice one.
Okay, vacuum, or you can go on to even intralesional collagenase, okay? So this is the prototypical patient that we're talking about. All right, and these are the recommendations that we talked about, the Peyronie's recommendations. So the moderate recommendations here were offer intralesional collagenase histolyticum with modeling by the clinician and patient for curvature reductions. This is a grade B recommendation, okay? And intralesional verapamil, you can see is the evidence of efficacy is very weak. And the moderate recommendation here is patient has stable disease, requires greater deformity correction than possible with intralesional treatments, but he has erectile function that's normal. So the moderate recommendation is offering a tunical plication and or plaque incision, all right? So just want to go through this very quickly. The FDA labeling, is this an appropriate format? Yeah, okay.
That's excellent.
Okay. Collagenase is the only FDA-approved medication for Peyronie's disease. Classically, you want a curvature of 30 degrees or greater, up to 4 cycles of treatment, to be discontinued if the curvature is less than 15 degrees or if not clinically indicated. And the contraindications for all the residents are plaques that involve the urethra, or there is hypersensitivity to collagenase. Okay? All right. So baseline curvature less than 60 degrees, curvature improvement is 50 degrees. Baseline curvature greater than 60 degrees, you have a curvature improvement of only 25 degrees itself. Complications, ecchymosis, edema, penile pain, black box warning, corporal rupture. Okay, this is the IMPRESS 1 and 2, and you saw nearly 1% of patients who had this thing and 3.7% incidence of hematoma. After a intralesional injection, and he comes back to you, Dr. Hamid. I also thought I heard a pop. What are your thoughts?
Might be a rupture of the tonica.
Okay, great question. How would you manage that? You have 5 choices.
It's a penile fracture.
Well, I'll go for
That's a hint.
surgical exploration.
You go for?
Surgical exploration.
Okay, all right. So as a dictum, I'll tell you, you're going to go for your boards. You're going to go for a fellowship. Always be conservative. Always go from less to more, as a rule of thumb. Okay. I know we all want to correct the thing, but always, and more importantly, even though you suspect the diagnosis, you have to establish diagnosis. That's critical. Okay? So you're right. Absolutely correct, Naif. All right, this is what he presented with. This is the hematoma and all this bit. All right, so this is, what are you seeing here? Particularly look at the images on your right.
Yeah, I see a loss of continuity of the tonica.
Perfect.
With the hematoma.
Perfect, and you can see how significant it is, okay? So two abstracts were presented with hematoma. 4 fractures in 67 men treated, 27 men treated, 3 non-traumatic fractures. So you can appreciate even collagenase, even after molding, you can certainly disrupt it. And I think it's not that it happens in everyone, but the incidence is certainly there. All right. Prototypic patient Peyronie's disease, again, for the guidelines, I think we're all okay with this. Collagenase improvement, 34%. Complications, timeline, and surgical correction dates you're looking at over time itself. In terms of surgery, you yourself, stable disease, sexual intercourse, difficult or painful, failed intralesional injections, or can be the patient preference. You can just move on to that algorithmic pathway itself. Okay, choice of surgical approach. When the penile rigidity is adequate, who's going to take this? Let's have another resident.
If you want to have our fellow here.
Fellow, perfect.
The victim is here. Dr. Abdul Malik.
Okay, Dr. Abdul Malik. All right. Sir, choice of surgical approach. When penile rigidity preoperatively with or without oral pharmacotherapy, you have tunical corporoplasties, curvature classically 60 to 70 or less. There's no hinge or destabilizing issues, and plaque incision or excision and grafting when the curvature is more than 60 to 70 degrees. All right, with that, let's look at our next patient. How would you go ahead and do your corporoplasties intraoperatively if you had a patient who had a curvature of 60 degrees? What are the approaches that you can use?
You can use the blancation if it's 60 or less.
With normal penile length. I'm sorry, I meant to correct that. With normal
With normal penile length, we will use the application.
Perfect, perfect. So you do application. How have you done applications? Okay. Knife, what do you use for your application sutures?
I use actually a Prolene as inverted stitch with a node inside.
Okay.
And then I'll overrun it with a BDS 2.0.
Okay. With a PDS?
A BDS.
BDS.
Yeah,
okay.
because it's the handling is good. Plus, there is less irritation of the tissues.
Okay. So, like you, I use a 2.0 PDS, and I'll tell you why. I don't want it to be a permanent. Prolene is going to be there for a long, long time.
Right.
Okay, and PDS sutures will go away at 3 months. They start to dissolve. At 6 months, they're gone completely. All right. I use, similar to what you just said, you can invert the sutures or you can use it. It's your choice. You can do it either way, and I do it both ways. But my choice is to use a PDS suture, and I use a special needle. It's a special curved needle that's special ordered that we do over there, and because it gives you the fulcrum to come through the tunica on either side of the incised area.
So, Dr. Nora, just a question. So you delayer only the first layer of the tunica, but you don't see the tissues?
I don't.
Okay.
Very important. The moment you see you've gone too deep, you're going to get a hematoma, and invariably what you want is once you are doing that, you know exactly where the second layer is. So you, as the first layer gets disrupted, you're placing your sutures through both layers. Okay, but I don't incise the second layer.
Okay, so you don't see the erectile tissue itself, you just incise it until there is a superficial second layer of tunica.
Yeah.
But the needle itself goes through and through.
Yeah, the needle goes through and through the 2 layers.
Okay.
The 2 layers.
Okay, that makes sense.
Yeah.
What are those ices? That was the full name, and 3 ices on the side.
So I put that slide up because there's a number of surgeons who use Alice's to see the tension that they want to be able to utilize intraoperatively, okay, to tie the suture down. With a PDS suture, I tie it down fairly firmly, and you saw from my earlier presentation, if there's a second plication needed in a patient who has normal penile length, I'm not worried, because I can tell you at best I lose half a centimeter.
Yeah. Yeah. So do you always elevate the neurovascular bundle, or only if
On a dorsal plication? It's very, in my opinion, it's very important if you're going to go and not lift up the neurovascular bundle and place sutures on both sides. What you have is you have shortening of the tunica, but on the middle you don't. So what happens is it's going to bunch up.
Yep.
All right. By lifting up the neurovascular bundle, and we do it, you're getting. First of all, I don't use the cautery. By lifting the neurovascular bundle, I use a bipolar if I need it ever. And if I do it, I will get maybe some anesthetic areas that over time, 3 to 6 months, they come back.
with the tourniquet?
With a tourniquet.
With the tourniquet.
Yeah. I don't. So no, underneath buccal fascia, I come down to the tunica albuginea layer. All right, and then I incise the outer layer, and then I start to plicate. Correct. No, so there's a reason, this is very appropriate to our discussion. What do you think happens if in an adult male, and I'm classifying this, because we've actually studied this. What happens in an adult male that you do a tunical excision on long term? Got the diagnosis up front. You're creating a site-specific leak. Guaranteed. On the other hand, I can't answer this question, but this is a very good study that we should do. In the pediatric population with congenital cordis, pediatric urologists remove tissue, remove the tunica albuginea. They don't develop site-specific leak. I don't know the answer why. I have to, I probably will study it at some point. That's been something of a big interest, what happens in the pediatric population that's different than the adult population. And it may be the type of collagen, and the collagen over time in the adult manifests itself differently.
Makes sense. So do you cut it vertical and suture transverse?
Yes. Well, that's you can cut it. You can do it that way. That's a Yashia maneuver.
Right. Yeah. The HM.
Okay. Yeah.
Okay.
The reason why I ask is I'm sure you're aware of David Ralph's London group.
Yep.
And what they do is it's common practice to do right resection. And the long-term data does not demonstrate the presence of any issues such as venous leaks. So what's your take on that?
So
The reason why they don't have a head and chest study or
it's a good question, but I think if you look at our guidelines that came out in 2016, we actually recommended plaque incision. Okay, this data was looked at very carefully. Not my personal bias, I personally do plaque incisions as I've shared with you, but we actually had an independent arm that reviewed from 1960. So both the ED guidelines and the Peroni's guidelines, we had, the AUA spent $1 million just on these two arms of ED and Peroni's. I have to compliment, I had to push the AUA hard, but they spent $1 million, and what we have done now is we have established in our cohort for this subgroup, both for Peroni's and for ED, went back to 1960, so we don't need to go back for future guidelines to this thing. We just go on from 2016, 2017, and beyond. And that's why we know that that's what happens. That recommendation was based on expert opinion and studies itself.
So, Dr. Nahra, we have 10 minutes if you want to discuss another case.
Yeah, another case. All right. Who else is up for the next case? This is a complicated Peyronie's disease with a dorsolateral curvature, destabilizing hourglass deformity at midshaft. He has no erectile dysfunction. Options, what would you do here?
Khalid.
Khalid. I heard Khalid. Yes, sir. You have basically 4 choices because with Dr. Naif, you're going to be the stopgap, this thing. You're going to manage this patient yourself. So.
Can I see the previous slide, please?
Pardon me?
Previous slide.
Previous slide. Can you show me the previous slide? Let me see. Previous. Go right here. Here you go.
Okay. Maybe I will go with the partial excision with graft.
Okay. All right. So let's see what the answer is. This is what he has. It's very hard for this patient to be treated with a graft. Dr. Naif, what do you think?
Yeah, I'll do a complete penile disassembly in this case. I'll mobilize urethra, I'll mobilize the neurovascular bundle.
Okay.
And I agree, it's really a difficult scenario, but so good erection with a hinge effect.
Yeah. Significant hinge effect.
It is.
Significant hinge effect, and you can see how it's displacing the contralateral tunica albuginea. Yeah. All right. So here, the patient has stable disease. It requires a greater deformity correction than possible with intralesional treatments. And the moderate recommendation here would be tunical plication and or plaque incision with grafting. All right?
So the material, Dr. Nahra, you said you use SIS. I thought in North America now, because this is the way I was trained, it's a bovine or porcine pericardium.
SIS, same thing.
Which is, which one it makes it, what do you call it?
The pelvic
The pelvic or which one you use? Huh? Tutoplast.
Tutoplast.
Tutoplast, yes, tutoplast.
Tutoplast. So
Okay.
tutoplast is pericardium, and correct?
Yes.
And the issue in North America with pericardium, tutoplast is not being used as much. Why? Exactly right.
We use bovine here.
No, it wasn't the Jewish community. There were some contagions found. All right, some disease processes found. So that's why tutoplast fell out of favor.
I heard about the mad cow when they stopped it when there was a peak of mad cow disease, but then it's being used now.
Yeah, but it's not being as used as frequently as the SIS.
Yes, yeah.
Okay, let's go on to all right, this is a complicated Peyronie's disease with erectile dysfunction. So he has with erectile dysfunction. Khalid, you'll stay on this case?
Yes.
Perfect. 60 degrees dorsal and lateral curvature. So he's got a biaxial deformity. He's got a dorsal and lateral. He's got a destabilizing hourglass deformity at the midshaft. And he has erectile dysfunction that's refractory to medications. Here are your choices.
I will go with the D, inflatable penile prosthesis.
Cool. Awesome. So this is exactly what we agreed on, and you will go on with that particular issue with penile molding itself. And that's great outcomes. So I hope everybody heard. How would you place a penile prosthesis here in this particular patient? Do you use an infrapubic or a scrotal approach?
No, I will penoscrotal approach.
Okay, you want to do a scrotal approach, no problem. And once you do it, how do you do your penile molding? Because just by putting a penile prosthesis in a greater than 60-degree curvature, it's not going to self-resolve. So you'll have to do some
Plication
molding.
again.
No, you don't do plication. You'll just mold the penis. Just mold the tunica. All right? Remember, 15-second increments. You do it with the device about 70 to 80% inflated. Okay?
But don't do it after you put the pump because it can
No,
destroy
not after.
the valve.
It's pre-placement of the pump in the scrotum and with rubber shots on the exit tubing to make sure that you're avoiding back pressure on the pump itself. Back pressure on the pump and the reservoir. All right, after placement of an IPP, 30-degree curvature results. So you'll see that you basically went ahead and did some molding itself, and that's exactly what you did. Here, this particular slide, you see what you don't want, you never want to see this, all right? And you never want to see the exposed cylinder itself. All right, that's it.
Excellent. Any questions, guys? And there's a question there.
Patients who have a what?
Who have a thick plaque.
Thick plate, yeah.
You don't recommend that they go for the CCH injections?
No, I didn't say that. I didn't say that. I said you can go with a thick plate, meaning a thick fibrous scar.
You said invading into the deep into the corpora.
Oh, gotcha.
Yes.
So absolutely right. So what happens is that you're not going to inject the CCH into the cavernosal spaces.
Okay.
You're injecting CCH at the level of the tunica. But if the fibrosis is extending all the way down, the chances of your optimizing results for CCH are going to be limited.
So do you have strict criteria where you select patients for Clostridium histolyticum, or you exclude them?
I do. So I was giving you my bias. This was my bias, where if I feel that there's scarring that's extending to the corpora cavernosa, I will not give CCH to those patients.
Okay.
On the other hand, I showed you a second slide where there was a thick calcified plaque just covering the tunica. That's a patient I will give CCH to.
But other than the ultrasonographic appearance, is there any other criteria for selecting the patient if he has a good erectile function?
I think if he's got good erectile function, a curvature of 30 to 60 degrees, absolutely.
Okay, thank you.
Okay, anything more than 60 degrees, CCH is going to improve the curvature, but will not resolve the curvature.
Thank you.
A question, Dr. Nahar. So do you ever do any penile lengthening procedure as adjunct to the prosthesis itself? Because I see now people in Italy, they're advocating for the sliding technique by Giuliano, and people are advocating for oversizing the prosthesis itself. Your measurement is 20, you put 22, especially in elastic penises. Or, fixing the, you see all these new funny, I don't know if we have a good literature on that, but do you ever opt if patient tells you, can you give me another 2 or 3 centimeters to the prosthesis?
Yeah, so it's a great question. Everybody seems to want extra penile length, but let me tell you, from the stretched length that you have intraoperatively, you're not going to be able to get any additional length. So all you're doing is changing the perception by the patient. I'm being very candid with you. So there are 2 authors. One was doing where he was disrupting the fundiform ligament.
Yes.
Okay? When you disrupt the fundiform ligament, you're actually creating instability. All right? When you create, and initially you create instability, long term you create severe fibrosis.
Interesting.
All right? Lawsuits happened.
Right.
Stop. Second author is using the ventral, so instead of like I use the word perception changes in length, what happens is on the penoscrotal junction with the median raphe, you can disrupt that and you can perceivably gain some additional length, but you don't change length. I think what you asked is a great question. Should you oversize? I would not recommend oversizing. I rarely use rear tips. I never use a rear tip of 2 centimeters. I use a rear tip of 1 centimeter or no rear tips. Why? Because if you do that, you're maximizing your inflatable component of these cylinders to get a great quality erection.
Yeah.
And what happens is a lot of surgeons will use 3, 4, 5 centimeter rear tips and use less inflatable components, and that's where the problem arises.
Yeah. That's not good.
That's not good.
That's not good.
Khalid, ask you a quick question. Intraoperatively, you're going in, you perforate the crus on one side. Would you abandon the procedure? Would you, and you've placed the cylinder on the contralateral side already. We have 2 minutes, right?
Almost done with the time, but we can take this question.
Okay, so one side, you've already closed the tunica albuginea, you've placed the prostheses, you were going to go ahead, but you perforate the crus. How would you manage that patient?
And
Would you explant?
It is
would
well
you-
dilated.
Would you, during dilatation, you perforate the proximal segment?
I will go with a larger size dilator, over dilate on it to the correct pathway, and I would sit put it. Keeping in mind the urethra is not.
No. So you've already perforated the crus.
There is a
Proximal.
There's a proximal perforation.
Ah,
That's the term.
Proximal crural
So
perforation.
there's a difference in the 2 dilators.
Yeah.
And you push the dilator, it goes all the way. So you perforate it. That's his question.
Okay. So I would leave the side that is implanted already. I will close the other side. I will come again to insert the other side. It's malleable, right?
No, it's inflatable. So I'm not putting you at a spot. It's a good question. I'll tell you.
Dr. Nahra, we have our ex-fellow there, Dr. Sultan. Go ahead, Sultan.
Professor, how are you?
In this case, with the vertical line procedures, I will stitch up and put the tubing or the connection of the cylinder to the pump. So one stitch up and one stitch down, and we'll anchor it there. Okay. The other one, which is previous, was done, but nobody, I mean, do it just that would be sling like with the like the through and through the needle or BDS or pike reel through the tip of the extender and down and make it up and make it as to just to protect the viral process from not going down. So I prefer which is put one stitch up and one stitch down in the tube.
Okay.
So this is what I will do.
So when you say the tube, you're not talking about the cylinders, you're talking about the exit tubing.
Yeah, exit tubing is above and loop.
Okay, so that's reasonable. That's not a bad approach. But you're not changing the size of the prostheses on that one side that you've perforated?
No, I will not.
So I'll tell you the latest thing is, you know the size, leave it alone, don't inflate the device for 8 weeks. You'll get the same result because you'll scar that perforation.
Yeah, that's a very good point.
You're not stating anything incorrectly, don't misunderstand me. But the new dictum is, it's okay, just put the device in, leave it alone for 8 weeks, come back.
It will fibrose. It will just fibrose there. No, some people, they just fix the rear tip extender in that hole,
Yeah, yeah.
extend your corporotomy proximally,
You can.
fix the tubing, and there is 100 ways to skin a cat. But I think
And, you know, you're welcome to come and see how we do this. It's not a problem, or if there's an opportunity in the future, we can do it here, but we don't want to get into perforations at all.
excellent. So this comes to conclude our session. Thank you so much, Dr. Nahra. Great session. Thank you.